Shashikala ma'am will be starting, Marti ma'am.
Yeah.
Yes,
Yeah.
I am starting. Good evening to all. Welcome to Ask Your Mentor Program Season 3, organized by Tamil Nadu AOMSI. Today's topics are maxillofacial hard tissue and soft tissue reconstruction. Mentors for these sessions are Dr. Rajshekhar Gali for maxillofacial hard tissue reconstruction and Dr. Magati for soft tissue reconstruction. The moderator for the session is Dr. Sandhya Bhogavaram. Dr. Sandhya is a consultant head and neck surgeon, ENT department, Apollo Hospital, Hyderabad. She had completed her graduation from Rajiv Gandhi University of Health Sciences, Bangalore, and master's from Government Dental College and Hospital, Hyderabad. She holds IAOMS Fellow in Maxillofacial Head and Neck Oncology and Microvascular Reconstruction Surgery, Sangod 9 People Hospital. Also Fellow of International Federation of Head and Neck Surgeons and Oncologist, MSK, USA. She has been a speaker in various conferences. She has many international and national publications to her credit. We welcome you, Dr. Sandhya. May I now request Dr. Sandhya to introduce the mentors and
Good evening, everyone. First of all, I welcome Dr. Mahati Narela. Madam is an oral oncologist and professor at the Department of Oral and Maxillofacial Surgery at Savita Dental College. She has completed her graduation, her post-graduation on oral and maxillofacial surgery from Faculty of Dental Sciences, Sri Ramachandra University in the year 2012 and joined Oral Oncology Fellowship at Kidwai Memorial Institute of Oncology in 2013. Since then, Madam has been actively and working full-time in oral oncology and associated with Savita Cancer Institute and Savita Dental College. She has independently performed lots of head and neck procedures, oral oncology procedures, resections and reconstruction with locoregional flaps, and also assisted multiple microvascular reconstruction flap for oral oncology cases. She is associated with the Savita Dental College since 2014 and has multiple, about 30 publications to her credit, and has spoken in numerous conferences and also conducted multiple workshops. Welcome, Madam. Kindly let us now start with the reconstruction of soft tissue.
Yeah, thank you for the introduction, Dr. Sandhya. So shall I share my screen? Is it visible?
Share the screen? Yeah, I can see that. I can see.
Yeah. So today I'll be the maxillofacial surgery and hard tissue reconstruction will be taken by Dr. Rajshekhar Gali. So coming to the first. So what are the various reconstructions in OMFS? Soft tissue reconstruction is required after ablative cancer surgeries, after residual trauma following high velocity, residual defects following high velocity trauma, in cases of burns, and in cases of extensive infection. Soft tissue reconstruction and isolation combination tissue reconstruction. Here we are seeing the reconstruction ladder. The old one where secondary intention, primary closure, delayed primary closure, followed by split thickness extension, local flap, pedicle flap, and the free tissue transfer. But now, revised reconstruction ladder, free tissue transfer is preferred choice first, followed by the local flaps, and then if required, tissue expansion, delayed primary closure, grafts, by primary tension. So these grafts can be full thickness, split thickness, as we all know. And the flaps, they are divided into local flaps, pedicle flaps, and the free flaps. These local flaps can either be axial pattern or a random pattern. Axial pattern means they're based on a predictable blood supply. So the important considerations that before we do soft tissue reconstruction is the cosmetic or the aesthetic subunits of the face, relaxed skin tension line, and the so the face as such is divided into multiple cosmetic subunits. These are called a specific qualities of texture, pigmentation, elasticity, and thickness. So ideally, local skin with similar qualities within the same aesthetic zones, they conceal the scars and they are considered to be ideal. So relaxed skin tension is determined by the orientation of the collagen fibers, and these lines run perpendicular to the lines of maximal. So remember this, and our incision should be parallel to the relaxed skin tension lines. So coming to the first rung, that is secondary intention according to the old intention. So healing left to heal by secondary intention, wound left to heal by secondary intention will result in a broader area of scar tissue and is therefore inadvisable. But in superficial defects of concave subsites like medial canthus and conical bowl or the mucosa, healing by secondary intention can be used. We can leave the wound to heal by secondary intention with good cosmetic results. So healing by primary intention is opposition of skin edges to permit healing without granulation tissue formation. So ideally, lines of primary closure should coincide with boundaries of anatomical subunits wherever possible. Next comes grafts. The third, they may further categorize as simple if composed of a single tissue type or a composite. Generally, autografts I'll show a case where we have used a full thickness skin graft for a case of following some injury to the left ear. So here we have used full thickness. Here we have used full thickness skin graft mining, and we did achieve some good results in this patient. And cases of split thickness skin graft, actually in oral and maxillofacial surgery, we can use split thickness skin graft after the excision of fibrous bands following oral for that. And we also can use following where we have used a huge flap size for PMMC harvest. Now, what we commonly use is the collagen, which is a xenograft, actually bovine collagen. Revolutionized oral and maxillofacial surgery. It's very pliable. I find it very useful. Instead of taking split skin graft, I use it mostly nowadays for all my cases. I use this. So this is a case where we have placed collagen with the good results following buccal mucosa excisional biopsy. This case I think was the excisional biopsy. A little bit a big, I think it was dysplasia. So this is another patient in the same way. And we also use it after this case we did recently, day before yesterday. So plus vestibuloplasty, we have used collagen, and this is POD3. So we expect good results. We all actually we have good experience in using for a vestibuloplasty also routinely in our collagen after vestibuloplasty. So next comes.
Yeah, can I ask you small information regarding the collagen graft?
Yeah.
Yeah. What could be the cost of this?
This costs 10 into 10 centimeter costs around 100 rupees actually.
Oh, okay.
So
okay.
it is very.
Yeah. Can be used in routine dental
Not-
practice as well.
Yes, we actually are making split skin graft. We are using routinely collagen in our college actually.
Okay. That's lovely. That's actually a good
Yeah.
information. Yeah. And then the next question now is the relevance of locoregional flaps in maxillofacial reconstruction. Could you
Yes.
please elaborate on that?
Yes. For maxillofacial reconstruction. So local flaps, then comes the regional or the distant flaps and the free flaps. Local flaps can be either axial or random. Our flap classified is based on the method of movement, and based on the composition. So based on the method of movement, local flaps, they can either be an advancement flap, rotation, transposition flap. Only is between position flap, the base of the flap is contiguous with the defect, but in an interpolated flap, only the tip is used, and then we have to do a two-stage. We have to divide it after maybe 3 weeks. So that's the only difference. So we have very minimal application of these flaps in maxillofacial, oral and maxillofacial surgery. So mostly they are used for any defects on the face, like after any small trauma or basal cell carcinoma. So flaps. There are many types of advancement flaps. So I've just taken few pictures. I don't have any my own case photos. I've just taken from the textbook. So where we can surgeries maybe after any excision of any tumor near the vermin. Once yes, that's the only thing. And so next is the rotation flaps. Rotation configuration. So to the bowels or the excised tissue, we just make at a angle, and then we have to rotate it and use it. So next will Burroughs triangle getting formed. Sorry, dog's ear or the standing cutaneous deformity getting formed. So we have to excise it and then close it. And next is a transposition flap. So the difference between transposition and the rotation flap is that rotation flaps will have a curvilinear configuration. Transposition flaps will have a or a transposition flap. The only difference is in the design. And as I said, interpolated flaps. One example of interpolated flaps in MaxFax is where we use forehead flap for nasal tip reconstruction. So that is an example of interpolated flaps. So I'll be talking about it with the tissue expander. So there are a lot of local flaps. So I'll be talking today about palatal flap, tongue flap, nasolabial, forehead flap. We also have plasma, trapezius, pectoralis major, delta pectoral. So most commonly we use the pectoralis, delta pectoral, and latissimus dorsi. Latissimus dorsi is also very uncommon in our institute. We mostly use pectoralis and delta pectoral. So the tongue flap, the most versatile commonly. So you can either use it from the dorsal surface of the tongue or lateral tongue flap, depending on to use it for reconstruction. So this is a case where a small lower alveolus verrucous defect, the carcinoma defect. So we have excised it and used the lateral tongue flap for closure. We can see that it has got it has achieved a very good closure. So we have to divide it at a later stage. So complications are also only is taste alterations. So when we have other we can avoid lateral tongue flap at least. So this is the example. This is not case. This is an example of dorsal tongue flap where we can use this for palatal defects. This is central communication where they have used a dorsal tongue flap. Next is a palatal flap. We all use it, so I'm not going to be talk elaborately on this. It is predictable option. It can be raised either as an axial flap or as a random flap. We most commonly use it for any orantal communication along with the buccal advancement flap. So 75% of the palatal mucosa can be actually used for defects of up to 16 centimeters square. So it's a simple local reconstruction option. We always use it in MaxFax. Next is the nasolabial flap. So nasolabial flap is also a very commonly used flap for after oral submucous fibrosis excision, fibrotomy bands excision. So it is again a random or an axial pattern flap, and it can be used to reconstruct small to medium-sized perioral and intraoral defects. It's also a good flap for nasal tip reconstruction. It is either we can harvest it like superiorly based flap or as an inferiorly based flap, and there are also other subtypes like this is an inferiorly based flap. So we can pedicle it inside the oral mucosa into the buccal mucosa. This is after the excision of a buccal mucosal tumor. We can use it, or we can also use this as an island flap. And so the advantage of using an island flap, you don't have to. This is a facial artery muscle flap where for any involving lower or upper alveolus, we can just use the soft tissue of the buccal mucosa, rotate it, and then use it for closure. Next comes standard forehead flap. It is no longer used because of cosmetic results that we get. But earlier it was used, and still it is used as the last option if at all PMMC fails, deltopectoral fails, or even we are not able to use microvascular tissue transfer. So this can be used as a last option, but this is actually gives a the extent of the flap. Actually, we can use it as for intraoral and extraoral seal. So this also is used. Two methods are: one, we have to use it, we can tunnel it within the zygomatic arch and use it, or if we're using it extraorally, we have to divide it in a second stage. Here they have not, this colleague's case, he has not meshed it, but he has achieved good results. So he has used a full thickness skin graft. The paramedian forehead flap is well suited for reconstructing caustics and nasal. So mostly nasal reconstruction or a small basal cell carcinoma excision involved the tip or the ala. This is an interpolated axial flap. So this is an example of interpolated flaps in MaxFax. This is based primarily of the suprachiasmatic artery. So this, if one more, you can combine it with tissue expanders and use it. So this can be primarily closed, and even cosmetic results are good. Next comes the temporalis flap. We use it very regularly in our institute. I couldn't get case photos, unfortunately, today. So this is based on anterior deep temporal artery, posterior and deep temporal artery. So its applications are, we can use it for orbital floor reconstruction. After TMJ ankylosis, ankylosing mass excision, we can use it as interposition graft, and we can also use it for up to the maxilla full. After total maxillectomy, we can use it. So we can tunnel it below the zygomatic arch, or if required, we can also fracture the zygomatic arch and then use this for more arc of rotation.
Yeah, now that we are done with loco-regional flaps, Mahati, could you please explain to us about the role of myocutaneous flaps in oral and maxillofacial surgery?
Yeah. So flaps can be called as myocutaneous, fasciocutaneous, or osteocutaneous based on the composition. So myocutaneous means it has a skin paddle and along with the muscle. Fasciocutaneous is only the fascia and the skin. Osteocutaneous means we also include a bone for heart tissue reconstruction. So the common myocutaneous flaps are the platysmal, trapezius, pectoralis major, submental, and latissimus dorsi. Submental flap, maybe we can use it for benign cases, but this flap doesn't have that much of a role after oral cancer excision because we need to remove 1A. So it will result in necrosis even if we use. And the fasciocutaneous flaps, we have got the forehead flap, which we already saw, delta pectoral and the supraclavicular flaps. So I'll be talking on pectoralis major. Flap is a again myocutaneous flap based on the and the of the inner memory artery. This is the workhouse of oral after oral cancer reconstruction. Anybody can harvest it. It's a versatile, reliable flap, and for large defects, we can even combine pectoralis major along with delta pectoral in the same patient, same time. And so how do we identify the pedicle? So we have to draw a line from the shoulder to the xiphisternum and the clavicle line. So we have to drop a line from the midpoint of the clavicle to the line from shoulder to the clavicle. And so this gives the pedicle arc of pedicle. This is for the pedicle identification. So here you can see 12 into 7 centimeter we have used. We have identified the pedicle and we have even harvested it. We for intra reconstruction. We can use this even as a bipaddle where extraoral and intraoral reconstruction can be done after deepithelializing the intervening skin. And then we also, if we are using large flaps, if we are not able to close primarily like this, we can even use split thickness or full thickness skin graft as we have used for one patient, not the same patient. Another patient, just wanted to show you this. So the modifications or the types of pectoralis major, this we have to know. Like a DP, we can harvest a full paddle and it after 21 days, or as an island flap where only the pedicle is harvested, or a muzzle paddle. This is the most commonly used type, or as a free flap. We can use actually pectoralis also as a free flap, and we can also include the fifth rib and use it as an osteocutaneous also. The only thing is we have to divide harvesting after elevation. We have to divide the lateral nerve. Otherwise, there will be stricture following closure post-operatively. So we routinely divide the lateral pectoral nerve.
Doctor, could you please elaborate on lip switch technique after?
Yes.
Yeah. Could you please?
So lip switch technique. Yeah. So.
Oh, sorry. This is a.
Yeah. Shall I talk about delta pectoral or just
complete about deltopectoral flap? I think it's a.
Yes.
Yeah. You have to elaborate about deltopectoral flap.
Next is the delta pectoral flap. So this is based on the perforating branches of the internal memory artery. And what we have to remember while raising a delta pectoral flap is this about angiosomes. What are angiosomes? They are arterial or vascular territories that are included when extending a delta pectoral flap laterally. So there is the delta pectoral groove here, and any flap outline confined within the confines of the delta pectoral groove will be the dominant blood supply for that will be from the first angiosome, and it is better. But when we want an extended flap, extended defect, we want to reconstruct, and when we are extending the flap over the deltoid muscle directly, that is over the this red portion, the supply will be from third angiosome, and it is not very predictable. The chances of necrosis is more. So if the blood supply is from the second and the third angiosome predominantly, then there are more chances of flap failure. Here we have used DP for a case where we have done major radiated, present with recurrence. We have done wide excision again. So we were left with no other option apart from using delta pectoral. So we had to use it over the deltoid muscle, and then we closed it. The results were postoperatively the skin part alone in near the tip necrosed, but still the wound edges did not break down. So we had good result than expected.
What was intraoral lining in this case?
We used this as the
defect, right?
bipadal, I think.
Okay, okay.
No, this was, yeah. We have tunneled it and used it.
Okay, okay.
Deepithelize the skin, I think.
Yeah. That sounds fair. And the next is lip switch technique. Could you please elaborate on that?
Yeah. So lip reconstruction is a separate entity based on the defect size. There are multiple options to choose from based on the defect size and the area, whether it's a central defect or a lateral defect. So upper lip and lower lip both, we have to see if it is up to 1/3 of the defect is involving 1/3 of the lip. We have to next see if it's a central defect or a lateral defect, and then we have multiple options to choose from for reconstruction. Lip switch flap is a Abbey's flap or Abbey's lip switch flap. So this was first popularized by Sabatini in introduced by Sabatini in 1838, but popularized by Abbey. It's a labial artery based flap. So the lower lip donor site is designed to be half the width of the upper lip defect and with a laterally based pedicle. So there is something called a reverse Abbey's flap, where the same concept we used to reconstruct the lower lip defect from the upper lip using the flap from the upper lip. This is mostly used, or initially it was used for cleft reconstruction, cleft bilateral lip reconstruction. Actually, I don't have any experience in using Abbey's flap, so I do not have any case photos for this. Next.
Yeah, could you next we can move on to microvascular reconstruction, and could you please elaborate on types of microvascular reconstruction?
Yes, microvascular reconstruction. We have so according to the new reconstruction ladder, free tissue transfer is the first preferred choice nowadays, and we also have moved from conventional flap concept to the perforator concept. The only difference is at the anatomical level of blood vessel dissection. So perforator concept is focused on the distal circulation called the perforator. The advantage that we have because of the perforator concept is that we have thinner sections of the tissue that can be taken and harvested. So we can avoid bulkier tissues. So there are a lot of microvascular free flap. What we commonly use is the radial forearm, anterolateral thigh, and fibula. We use these three routinely. Radial forearm is based on the radial artery, and there are multiple applications for radial forearm, and even a beginner can do it very easily. Ease of dissection is also there. We have a very good pedicle length, long pedicle, and the modifications is that we can either use it as a bilobe flap, where we can use simultaneously reconstruct bilateral buccal mucosa defects. We can also, if necessary, but more we don't use it as an osteocutaneous flap. But yes, we also use it, but we don't use it routinely. And if we want to use any as a free vascularized nerve graft, we can also include the radial nerve. So here I'm showing cases of reconstruction of tongue for after the maxillectomy, and the third case is of cleft reconstruction of cleft max. So this we have used it for after bilateral OSMF excision, fibrotomy. This isthmus will come in the lower vestibule. So any amount of skin from the antecubital fossa to the wrist can be used, and we have a long pedicle of about 20 centimeters that is available for use, and diameter is also good. Next comes the free fibula. I know that this will be spoken in detail in heart tissue reconstruction, but I'm just going to give a small overview. So free fibula for mandibular reconstruction, because we can do multiple osteotomy cuts. So from the amount of bone between 4 centimeter of bone from the head of the fibula and 6 centimeter from the lateral malleolus, we have to leave, and the intervening bone is ours. Up to 40 centimeter, we can use it along with the skin paddle. Here we have used this for post mucormycosis defect after maxillectomy, total maxillectomy, yes. So this is superficial peroneal artery and vessels based on vena comitans, and we can also use superficial peroneal nerve if needed. Even soleus muscle, lateral part of the soleus muscle can be used if needed. Next is the anterolateral thigh flap. So for huge resections and bulkier resections, we can use this. In this case, we have used for a mucosal defect following even commissure was involved with the excision. So we use this. But reduces actually later on.
Yeah.
So we draw a line from the anterior iliac spine and to the lateral part of the patella. And then we have to take a point about 2 centimeter lateral to the midpoint of this line. So around 3 centimeter radius, we get good perforators. We can use it, and one more primary good undermining. So this is based on the descending branch of the lateral circumflex femoral artery.
Yeah. Could you please elaborate a little bit on Allen's test for the postgraduates that might come as an
Yeah.
Yeah.
So Allen's test is we have to see if we are taking the radial artery. So if ulnar artery is sufficient to give the circulation. So we have to palpate for the radial artery, and then can I talk a little bit 5 minutes later?
Yeah, sure, please.
Yeah.
Then let's
can I just finish the rest and then
tissue expanders, and then we can come back. Yeah, sure.
Yeah.
Yeah, please elaborate about tissue expanders and their role in maxillofacial surgery.
Yes. So tissue expanders is this exploits the adaptability of the skin and induces controlled skin growth. And benefits of tissue expansion for the correction of cutaneous is the ability to use the tissue optimally matched in color, texture, thickness, and hair bearing qualities. So when the skin is stretched beyond the physiological limit, mechanotransduction pathways gets invoked. So there is increased mitotic activity and collagen synthesis. So there is net gain in skin surface area. So the epidermis demonstrates the ability to generate more tissue in response to expansion, but the other layers of the skin are simply stretched. There is also formation of capsule around the tissue expanders, and which aids in strengthening and thickening of the tissue during the early phase of the tissue expansion. So after removal of expansion, the tissue is restored to natural state and clinically returns to normal thickness and appearance. We have a variety of expanders available, and based on the area of the defect to be reconstructed and the size of the shape of the defect, we can choose the expander. So tissue expanders are implanted either with local anesthesia or under general anesthesia. The access incision should be in an area adjacent to the area to be reconstructed. And the incision for insertion of the expander is made with the careful consideration of the anticipated design and with respect to the preservation of vascularity and the motor nerve innervation of the area. So one more important thing is to create a sufficiently large subcutaneous tissue pocket to accommodate the implant without causing any folds in the expand. And we need to create a separate subcutaneous tissue pocket to accommodate the port through which we have to inject. Inflation of the expander is commenced 2 weeks after placement. And it is inflated with twice weekly saline injections to a total of 1/10 of the expander volume. This is my colleague who in her previous institution, she has used tissue expanders for reconstruction of cleft nasal deformities. So from as early as 1993, tissue expansion is in place. A lot of complications have also been told. So this is my where they have my colleague's case where they have used tissue expansion for taking a bilobed paramedian forehead flap for nasal tip reconstruction. I do not have any personal experience in using tissue expanders.
Yeah, what could be the, coming to the complete summary of the current presentation, what would you think that is an ideal flap for avulsed facial tissue?
We cannot tell there is no one ideal flap. So based on the knowledge that we have, based on the size of the defect and the location of the defect, we have to choose case base. We cannot tell there is this is the ideal flap, I feel.
Yeah. As you said, sometimes the thickness, sometimes the component, internal component, like if you want muscle or if you want just the thickness of the flap or just the skin, depending upon what we are reconstructing, whether we are reconstructing the full thickness or whether we are reconstructing the partial thickness of the defect, we can choose the flap. Coming to the previous question, actually about Allen's test, briefly, if you could explain, because that I guess is a very important question for the exams for post-graduation.
Yes. So this Allen's test, actually, we have to, the collateral circulation has to be checked. So only if there is collateral circulation, we can use what to say, the flap from that hand.
Yeah.
So yes. Can you elaborate on that?
Yeah. It's simple. It's a very simple test by which you just exsanguinate entire blood of your
because we have to exsanguinate the ulnar artery and then check the so both
just press both the sides on the radial side as well as on the ulnar side after you've exsanguinated entire palm. And first you just try to because we will be using the radial side, right? We have to check if there is a cross circulation from ulnar side. So what you do is just release the ulnar side and see if the color is being from all the fingers until the thumb. So this is a simple test just before deciding to select a patient for a radial forearm flap reconstruction must be done to ensure that the blood circulation from the ulnar side is good enough for remaining hand.
Yes, and I wanted to mention that like for ALT and we actually use the Doppler routinely.
Yeah.
So
right. Mostly Doppler has utility of Doppler.
Perceive these tests.
So yeah, right. All perforators can be very precisely marked, and then the flap can be planned exactly from the distance of the perforators.
The advantage is like you can use it on the bedside. Anybody can do it and just check.
Right.
If for a
Yeah. Thank you for lovely presentation. I think we will reserve the questions after Dr. Rajashekar has also spoken about the heart tissue reconstruction. Thank you very much, Dr. Mahathi.
Thank you for the opportunity. It was wonderful presenting to the audience.
Next, is it connected? Still connected? Yeah, okay. Our next speaker for today is Dr. Rajashekar Gali. He's done his undergraduation from SRM Dental College and post-graduation from Sri Ramachandra Dental College. He's done his undergraduation. He passed his BDS in the year 2001 and his PG in the year 2006. He's currently the professor in Narayana Dental College and has published numerous articles and in well-reputed journals, and is very popular among his students for being a very good teacher. Sir, could you please elaborate about heart tissue reconstruction in maxillofacial surgery?
Thank you, madam. Thank you, organizers, for giving an opportunity to try to share my ideas and facilitate clearing the theory exam for the postgraduate residents who are giving their exam. 1 second, I'll try to share my screen. Yeah. Is my screen visible, madam?
Yes, sir. Yes. First question for you is what could be the maximum size of the defect that can be reconstructed using a graft beyond which a flap needs to be used?
Yeah. So a literature search reveals survival use of longer non-vascularized grafts to the extent of around 12 to 13 centimeters also have survived. But a systematic review which has been published in the year 2016, which had studied around articles which have been published over a period of 36 years, had put the bar at around 6 centimeters. So 6 centimeters is the maximum size of the defect that can be managed by a non-vascularized bone graft with minimal amount of complications. This study goes on to describe other 3 critical factors which they say has been found to be associated with failure of the non-vascularized bone grafts. They are the length of the defect. If you can restrict it to less than 6 centimeters, it is probably associated with better survival or revascularization chances. The next method is the fixation. The next factor which can influence the survival of the graft is the fixation method, because non-rigid fixation, that is transosseous wiring, will permit some amount of mobility of the fixated graft segments, and it might lead to non-union, ultimately exposure of the graft, or even a mini plate fixation, which is sort of a semi-rigid fixation. If there is failure, like loosening of the screw, plate fracture can result in non-union. And infection has been found to be another factor which is associated with the highest percentage of failure of non-vascularized bone grafts. And they found out that other factors which are responsible for success or which dictate success is that the recipient bed has to be well vascularized, and if it has got sufficient soft tissue cover 3-dimensionally, and if you're able to give a good mucosal lining, it will generally heal successfully. In our group had published a study that had evaluated the use of non-vascularized fibular grafts for mandibular reconstruction in benign pathologies, and our defects ranged from 6 to 10 centimeters. We had evaluated them for a shorter period, of course, only for a 1-year follow-up period. And the lessons that we learned from this study was that if you had used non-vascularized fibula for benign resections, that is ablative procedures done for removal of benign pathologies, in you end up putting them in a good non-irradiated bed, which is well vascularized compared to, when you use it for a malignant scenario. And if you're able to give a good soft tissue cover over it, and if the defects are linear, they generally tend to survive well, and they generally tend to get revascularized. The most important lesson that we have also learned in this context is that if you're trying to reconstruct a curved defect, like the one that you're seeing here, irrespective of the size of the defects, they can go in for a fix, or they can go in for avascular necrosis. The reason being, you're forced to do multiple osteotomies on the graft that has been harvested to restore the contour of the symphysis of the mandible. So the central segment here, which is not in contact with the native mandible or the residual native mandible, can go in for avascular necrosis. So this is another lesson. So these are all the various factors that can influence the survival of the graft, not just the length of the defect. So that is one point that I thought will be of interest to the postgraduates.
Yeah. Could you, what are the various reconstruction material used in our practice in maxillofacial region specifically?
This is one of the frequently asked question, either in the form of a theory question or in the form of a viva, when residents give their exam, when postgraduate trainees give their exam. And current day practice, there are a lot of reconstructive options that are available. They are autogenous, alloplastic, allogenic, xenogenic, and combinations of these. And autogenous are presently considered the gold standard. You are all well aware of it. And the autogenous sources can be broadly divided into grafts which are detached from the donor site and transplanted to the recipient site, and the survival of which is immediately dependent upon the recipient bed for revascularization survival. They can be of local, regional, and distant based upon the distance between the recipient and the donor sites, or they can be of cortical cancellous and corticocancellous. And of course, flaps are the ones which get their own blood supply in the form of pedicle myosous flap or vascularized flaps, where the vascular pedicle also will be harvested along with the tissue that is being transferred, which needs to be anastomosed to one artery and two venae committents at the site of the recipient site or transplanted site. Next is alloplastic, which can range from those that degrade over a period of time, which is known as resorbable. All these osteoconductive scaffolds, which permit cellular adhesion and bone formation through them, come under these, like hydroxyapatite, beta tricalcium phosphate, etc. And the other are non-resorbable, which contain metallic and non-metallic. Metallic are those like titanium, which we routinely use for reconstruction plates, and 3D printed patient-specific implants, which are the order of the day now. And of course, you have non-metallic of polyether ketone. And allogenic refers to same species of a different individual, like cadaveric bone grafts. The problem with this is immunogenicity and disease transmissibility. And xenogenic refers to of a different species, probably bovine, demineralized freeze-dried bovine bone matrix, and certain combination strategies like the use of osteoinductive materials like bone morphogenic protein can be used to enhance the performance of bone grafts or other bone substitutes like hydroxyapatite, or autologous bone marrow aspirate, either in a concentrated manner or unfractionated manner, can also be used to enhance their performance.
What could be the most common microvascular flap used for the hard tissue reconstruction in the maxillofacial region, sir?
Madam, this has been extensively talked by the previous speaker, so I will not be touching more upon it. But since you've asked, for bony purposes, for bony reconstructions, fibular osteocutaneous flap is the most commonly opted option, for the simple reason that the structural anatomy of fibula is similar to mandible in the form of a tubular cortical bone, and it permits harvesting longer segments of bone. Up to 24 centimeters can be harvested, since it has got a nutrient canal that runs through it, and also periosteal perforators which run along the entire length of the fibula. It permits making multiple osteotomies if required to contour the graft to conform to the bone that is being reconstructed. So these are some of the advantages. Apart from that, soft tissue flaps can also be used for reconstruction of bony defects in the case of maxilla, where the purpose is just to fill up the obliterate the bony cavity by using an ALT or a radial forearm fasciocutaneous flap.
Dr. Mahathi has briefly explained about reconstruction ladder. However, could you please explain in a context of bony reconstruction in maxillofacial region?
Nothing much to say about bony reconstruction with reference to reconstruction ladder. I thought I'll elaborate about reconstruction ladder from a different perspective. If you permit me to do so, can I?
Please, please.
The reason that this question was given to me was that probably this might have been asked as a Viva question or as a theory question to the postgraduates. To answer that, I thought I'll put it in a systematic manner like this. So what is reconstruction ladder? If somebody asks you, this is nothing but a systematic arrangement of various management options or reconstructive options that are placed in a ascending order of complexity, which will help a clinician to make a decision as to which option to choose to close a soft tissue wound. If you go to the history, this was actually given in the early 1920s by Sir Harold Gillies, who started treating a lot of war injuries. So that is, I mean, the options in that are if the wound, if you think the wound will heal by secondary intention, then the primary purpose for which it was given is that you should let it heal so, followed by ascending order of treatment complexity like primary closure, followed by delayed primary closure or a local flap or a free flap. The problem with this is it is not applicable to the present scenario. I'll give you a small example. If you have a small soft tissue wound, for example, you have a small tissue avulsion in the lateral canthus region or lateral to the lateral canthus region of the face. If you let it heal, it will definitely heal by secondary intention, ultimately giving rise to scar contracture, ultimately giving rise to severe cosmetic and functional deformity, which is not the optimum result nowadays. So strict adherence to reconstructive ladder is presently much debated. You should take it only as a guideline. In fact, this article was of interest. I came across this article.
Yes. I read this article. Reconstruction
Fu
pyramid, reconstruction lift. There are multiple other modifications which were. Could you please elaborate more?
Yeah, this was given by Dr. Fu Chanvi, who is considered as an authority in reconstructive surgery. He hails from Changgung Hospital in Taiwan. So he says it is only to be considered a historic milestone. No doubt it has helped so many clinicians over a period of 100 years, but things have changed. The present day patient is more demanding in terms of quality of life that you give by the treatment procedure that you do. So he calls for the development of individualized region-specific algorithm. It's not a one-size-fits-all solution. You cannot have, because the anatomical demands, cosmetic functional demands vary from area to area in the body. You cannot let a wound heal by itself as you would do on the back, like you would do on the face. So it varies. So he says you need to tailor make them, and that is where it stands as of today. But as a postgraduate, you're supposed to know it for your exams.
Yeah. Next, coming to the surgical procedure, could you please elaborate on principles that have to be followed while doing bone grafting?
Before we go into the actual principles, you should understand that presently autogenous bone grafts are considered as the gold standard as they give optimum results. The reason behind the success of autogenous bone grafts is because of these three critical elements. That is the mineralized portion or the cortical portion of the bone graft, which acts as a scaffold and which causes something known as osteoconduction, where the cells, which are the viable osteocompetent cells which are located in the bone grafts, will start laying the unmineralized matrix or the osteoid. And next is the presence of these growth factors, which are located in the cancellous portion of the bone graft, which induce the osteoprogenitor cells to osteoblastic lineage, and they start helping in bone formation. And of course, vascularity, which is very important in the case of vascularized flaps. Now, coming to basic principles of bone grafting, the most important thing when you are considering non-vascularized bone grafting, more specifically, is the recipient bed where you're going to place your non-vascularized bone graft. It should be well vascularized, preferably non-irradiated, and it should be free of infection. And you should ensure that it is encapsulated three-dimensionally by good soft tissue cover. And remember Billy's principle, that is, you should try to replace like with like as much as possible. That is bone with bone. Next is comorbidities, and future adjuvant radiation should also be considered before selecting the ideal reconstructive option, whether it is a graft or a flap. Now, how to choose between a cortical and cancellous grafts? Cancellous grafts, we should understand that they revascularize more rapidly compared to cortical grafts. For example, particulate cancellous bone marrow from ileum gets revascularized very fast than cortical bone. And there is basically difference in healing of cancellous and cortical bone. Cancellous bone first undergoes apposition or deposition of bone, followed by subsequent resorption, and it occurs generally more completely. Whereas cortical bone undergoes what is known as creeping substitution. All the non-vascularized bone grafts that you place, they tend to resorb first to an extent, slowly to be replaced by new bone. So it is resorption first, followed by bone deposition. So the next question regarding the next point that is to be considered while trying to understand basic principles of grafting is whether a bone graft or a vascularized flap. The factors that are to be considered are the size of the defect. If the defect is linear and if it is less than 6 centimeters, you can consider, and if it is if there is no possibility of being irradiated, you can consider putting a non-vascularized bone graft. If the defect is bone only, or it is a composite defect. For composite defects, one should always think about going for a pedicled osteomyocutaneous or osteomyosseous flap if it is possible, or probably a vascularized flap. And the next point that you need to consider is location, whether it is a linear or a curved defect and where it is located. Next is recipient bed, whether it is poorly vascularized in the case of osteoid necrosis or post-irradiation. Then the option will be to consider a vascularized flap. And patients with comorbidities, long operative time, donor site morbidity, cost factor, all these are negatives towards vascularized flaps. And you also need to consider the specialized training that is required to perform vascularized flaps and the instrumentation that is required. Taking in these factors into consideration, you should decide whether you can go for a non-vascularized bone graft or a vascularized flap.
So could you just elaborate about the choice whether to do bone grafting on the primary surgery or secondary at the later stage? Could you elaborate which cases needs to go in which way?
So primary reconstruction or primary grafting refers to where ablation as well as reconstruction are performed in the same operative session. Secondary refers to ablation alone is performed and at a later stage, delayed reconstruction is performed. So primary reconstruction is generally preferable as early restoration of form and function are possible, considering the more demanding lifestyles of the present day population. The advantages are you have a non-irradiated, well-vascularized recipient bed, which generally helps in better survival of the graft and revascularization of the graft. And if you're planning for a vascularized flap, availability of the recipient vessels is also good. The demerits are the long operative time that is associated both with ablation as well as reconstruction being performed simultaneously, increased blood loss, cost factor, etc. Secondary reconstruction is associated with the need for a bridging plate, something like a recon plate if you're dealing with mandible, because it has to act like a space maintainer so as to prevent the collapse of both segments of mandible. If it is a maxilla, you need to put in an obturator. And the advantages of using this approach is that it permits direct surveillance. You can pick up early recurrences in the case of maxilla if you're dealing with, for example, a sarcomatous lesion in a maxilla. Of course, there are the present investigative tools which can be used to pick up early recurrence like a PET CT or even otherwise other investigative tools. Nothing is as good as clinical examination. That is one of the advantages. The disadvantages are irradiated tissue bed. Putting a vascularized flap in an irradiated tissue bed will carry some risk of vessel thrombosis, etc., failure of vascularized flap. And you can have a vessel depleted neck, which makes it difficult for vascular anastomosis. So this is one study which I had come across, which had compared reconstructive outcomes of primary versus delayed reconstructions for mandibular defects. They say, as per their study, they studied around approximately 150 cases. And they say that there's not much of statistical significant difference between the reconstructive outcomes of both the groups. But of course, the major limitation was that it was a retrospective study design.
Sir, could you elaborate on how to treat anti-gum deformity?
Okay, madam. So one should first understand what is anti-gum deformity. It is basically an unreconstructed anterior segmental mandibular defect that gives an appearance of a severe retrogenia or a severely retrognathic mandible. The patient appears like he's not having the chin or chin prominence, or he doesn't have the prominence of chin and lip. So this anti-gum is actually the name of a popular cartoon character in the early 1920s, which was published in a daily newspaper which ran for about 40 years. It was very interesting to note that from these two articles, one of which was written by our famous Anthony Poggrel, who had done a lot of work on odontogenic keratosis also. So why this deformity is important is that it carries significant functional and cosmetic problems. The most important of which is the possibility of airway compromise, because you're taking off the central mandibular segment, which gives attachment to the genioglossus and the geniohyoid. So thereby, there is some amount of lack of support to the tongue and the hyoid bone, and there will be severe stomal incompetence, excessive drooling, mastication difficulties, speech impairment, etc. And cosmetic problem is also there. So the available management options for this are reconstruction plates is only an interim option. Ultimately, the overlying skin or mucosa will dehisce open, will get thinned out and dehisce open. So you can buy time to do a secondary reconstruction. And the other option is to go for a soft tissue cover with a locoregional flap or a vascularized flap and a recon plate. Again, this is prone for recurrence in the long run. One can consider doing a non-vascularized bone grafts, but as previously described, the need for osteotomies carries an inherent risk of avascular necrosis of the central segment that needs to be kept in mind. Vascularized bone flap is the standard therapy for such defects, which gives predictable and long-term sustainable results. And it also permits you to place implants, or even if the ridge height is adequate, you can even do a conventional dental rehabilitative therapy.
Sir, could you elaborate on reconstruction of maxillary defects? Final part of the
final question, madam.
Yeah.
Reconstruction of maxillary defects is a complex task because of the complex three-dimensional anatomy that is associated with maxillary defects. The goals of maxillary defect reconstruction are to restore oronasal partition and maintain a patent airway, restore speech quality, and restore a firm platform onto which you will be able to do some dental rehabilitation, and give support for the orbital contents if they are involved as a part of ablative maxillary procedure, restore facial symmetry. To understand how to reconstruct, we should first try to classify them. Various classifications have been proposed. One that still stood the test of time and is more applicable from a rehabilitative or reconstructive perspective is that given by Brown's classification. Initial classification was only of 4 types, class 1 to class 4. The revised classification contains 5th and 6th type. There are basically 2 components that you need to understand. One is the vertical component, the other is the horizontal component. Vertical component, class 1, refers to a simple alveolectomy defect where there is no oronasal communication, which is relatively easier to treat. And type 2 defect is a subtotal inferior maxillectomy defect where you have a oronasal communication. And type 3 will involve the floor of the orbit without touching the contents of the orbit. Type 4 will involve orbital enucleation or exentration. And 5 and 6, which have been added, 5 refers to orbitomaxillary, 6 refers to nasomaxillary ablative procedure. And the horizontal classification refers to a simple palatal fenestra, and B refers to unilateral palatal defect, C refers to an anterior palatal defect, and 3/4 defect, where only 1/4 of the posterior palate is remaining, refers to D. So various reconstructive options are available. Conventional option has been the use of split skin grafts to line the defect, followed by placement of obturators. This will buy you time to think about the survival of the patient and other factors if you're dealing with an elderly or if you're dealing with a malignancy, especially in elderly patients. And you can consider doing a secondary reconstruction at a later date. Or the other option is to go for locoregional flaps just to fill up the big cavity or obliterate the cavity in the form of temporalis myofascial flap, or free flaps, either if possible bone free flaps like fibula osteocutaneous, or the Westner's radial forearm osteocutaneous, where these bony struts will be used to replicate the bony struts that are located in the midface, like nasomaxillary buttress or allular buttress or zygomaticomaxillary buttress or your infraorbital rim, or only soft tissue free flaps just to fill up the defect. The present day COVID scenario, people have started using 3D printed patient specific implants, which can also be used, or combined approaches like the use of bone graft with a regional flap in the case of orbital floor, or an alloplastic material with a regional flap like orbital mesh along with temporalis myofascial flap in the case of orbital floor. So prosthetics versus reconstruction is another aspect as far as maxillary defects are concerned. Conventional approach was about using more of prosthetics. Advantages of obturators are they're relatively simple and you can easily restore the facial appearance to an extent, and possibility of cavity surveillance exists. The disadvantages are maintenance and because of constant change in the size of the defect, one needs to revise the margins and change it. The next option is to consider reconstruction, and the advantages are it obliterates the defects and restores the facial profile, and better patient compliance because there's not much of maintenance that is required. The disadvantages are obviously donor site morbidity, and zygomatic implants. With the advent of these, you can prosthetically rehabilitate that. Many algorithms have been published regarding reconstruction of maxillary defects. One that is displayed here is our own people who have published it in Indian Journal of Plastic Surgery, Dr. Subramanian Iyer sir and Dr. Thankappan sir. Class 1 defects, Brown's classification is taken for reference here. Brown's 1, nothing needs to be done. If possible, do a palatal flap, or if you want to restore the ridge that has been removed, think about doing a radial forearm. If other aspects permit you to do that. And class 2 defects, the options are to consider, if you're considering only soft tissue, to fill up the defect, radial forearm or ALT, or if you want a bony component, fibula osteocutaneous. Class 3 defects, same thing, to fill up the soft tissue, ALT is the flap, or if you want a bony component, fibula is the flap. Same thing holds good for class 4 defects. So as far as free flaps and maxillary reconstruction are concerned, for large volume maxillectomy defects with or without orbital exentration, they require microvascular reconstruction. Soft tissue free flaps are only used to fill up the defects, whereas osteocutaneous will help you to rehabilitate it by putting a dental implant, provided you restore the allular margin also. Thank you.
Thank you, sir. It was a lovely presentation.
Thank you, madam.
Now over to Dr. Kalpa to conclude the session, please.
Thank you very much, ma'am. With this, we come to the end of the session. On behalf of Tamil Nadu AOMSI, we would like to extend our heartfelt gratitude to the mentors, Dr. Mahathi and Dr. Rajashekhar, and moderator, Dr. Sandhya, for their valuable contribution and time. Now the participants are requested to stay back and fill in the Google feedback form, that is posted in the chat box. Filling up this is mandatory for your certificates. Please fill it up within 10 minutes. Thank you. Thank you, Dr. Sandhya, Rajashekar sir, and Dr. Mahati for the wonderful session. It was almost the entire reconstruction was covered in the session, so it was really beneficial for the PGs.
Thank you, madam. Thank you.
Thank you, madam.